Okay, we can start this session. So this is the first session of the program. The title is Health and Disease, Recent Advances, and we are going to, in this session, we have two key speakers. Domenico Praticò, I will introduce him later, and also Professor Eric Velázquez, both from United States. My name is Ramón Estruch. I has been the coordinator of the PREDIMED study that, you know, we have worked hard with the healthy effects of olive oil on the body, and I'm going to make a few introductions on this session on cognition, brain, and cardiovascular disease. You know that there are some evidence, weak evidence, that some foods can improve brain function, like vegetables and fruit, seeds, vitamins, folates, flavonoids, olive oil, fish, alcoholic beverage, coffee, and tea. But we know now that it's better to work with, not with a single nutrients, it's better to work with a new paradigm, that's the dietary pattern, because of the synergisms of the different foods and nutrients. So we believe that it's better to talk on Mediterranean diet than only olive oil, fruit, vegetables, etc. In this sense, there are several reviews and meta-analyses on the effects of Mediterranean diet and cognition, or systematic reviews, but it's systematic reviews and meta-analysis of accord studies, not intervention studies. So in the PREDIMED, we tried to demonstrate with the highest level of scientific evidence that Mediterranean diet works on prevention of several diseases, mainly cardiovascular disease and cancer. And in this study, we tried to analyze in a sub-study of the PREDIMED the association between the intake of key foods of Mediterranean diet with cognitive function in patients at high cardiovascular risk. And we saw in the first that there was a close relationship between some neuropsychological tests that overall cognitive function, and in this case, wine ranks in the first position on the protection against this cognitive function. In intermediate recall, total olive oil was also the food that ranks in the first position. In the legend recall, virgin olive oil, that's the same extra virgin olive oil than virgin olive oil in the PREDIMED, or coffee, and in working memory was nuts. Thus, there is some key foods that may improve this brain function, and we saw when we analyzed total polyphenols excretion in urine that was a close relationship between the intake of polyphenols and a better performance of immediate memory recall score and delayed memory recall score. So it seems, in our conclusion, that polyphenol-rich foods like extra virgin olive oil in Mediterranean diet may counteract against cognitive decline. But we also analyzed what happened with when we randomized the three arms of the PREDIMED. One arm was extra virgin olive oil plus Mediterranean diet. Other arm was walnuts and nuts and Mediterranean diet. And the third arm was the control group with not olive oil, no nuts, etc. And we analyzed what happened after 5 years of follow-up. And we saw that in the control group was a decrease in memory, in frontal cognition, and global. But in the other groups, the brain function maintains stable, or even in the group of olive oil was an increase. So the people improve frontal cognition in the arm of extra virgin olive oil plus Mediterranean diet arm. So we concluded that Mediterranean diet supplemented with polyphenol-rich extra virgin olive oil slow down age-related cognitive decline. But now we have two speakers who hope to complement this information. One is Professor Domenico Praticò. He's going to speak on extra virgin olive oil, brain health and cognition, the Mediterranean connection. And the other speaker is Professor Eric Velázquez from Cardiology Medicine, Yale University, who is going to speak on nutritional approaches to expand cardiovascular population health. CanOlive and olive oil led the way forward. So the first speaker is Domenico. He has studied medicine in the Sapienza School of Medicine in Rome. Later he moved to the University College of Dublin, more later to Pennsylvania, and now he's working in the Temple University, he's the director of the Alzheimer Center in Temple. He has published a lot of papers on this issue and has received many awards. So please, Domenico, thank you for coming. And I'm sorry.
Good morning.
Well, now we're moving to the second speaker. He's the Professor Eric Velázquez. He's Professor of Medicine at Yale University. He's an authority in heart failure, cardiovascular clinical trials, and cardiac imaging. He's going to talk on nutritional approaches to expand cardiovascular population health. CanOlive and olive oil led the way forward. Please, Eric. Thank you.
Well, good morning, everyone, and thank you to the organizers for this wonderful invitation. I've learned so much already, and I've met new friends, and hope to continue to work at this area with all of you. I recognize the audience is quite broad, not only scientists, physicians, clinicians, but also individuals from industry. So I wanted to focus my comments on really putting in perspective the role of cardiovascular disease and its impact on through dietary risk on outcomes, and then to help you understand what we know to date around the role of olive oils and how we can move this field forward. So just to outline what I'm going to focus on here, we're going to talk about cardiovascular diseases and how they contribute immensely to the global burden of morbidity and mortality, and to highlight that there's substantial geographic heterogeneity in cardiovascular disease trajectories as well as health and trajectories, and that might in fact be mitigated through population health differences in diet. And those nutritional contributions and dietary habits may in fact underlie some of the differences we see among populations in cardiovascular risk and morbidity and mortality. And to understand what to really recap really the amazing work of Professor Estruch here on the stage of establishing an understanding of the Mediterranean diet as a mechanism to actually prevent cardiovascular risk, and to understand the role of olive oil and what we know so far and what we might need to know into the future. So that's really the focus of my talk this morning. I'm sorry I don't have I have to look back here, but just to highlight that cardiovascular disease remains the leading cause of morbidity and mortality in the world. This is from the Global Burden of Disease investigators, and highlights the fact that ischemic heart disease particularly is the most common form of cardiovascular disease that causes that morbidity and mortality. That it is considered, of all the major disease categories, the disease category that's most amenable to rapid modification to impact global health. And that most cardiovascular diseases now occur not in rich countries, but in lower and middle income countries due to the change in risk factor profiles that is occurring and the benefits we've obtained from better treatment of infectious diseases in those countries. Now I'm going to spend a moment on this. We are living in a pandemic that we're all very much aware of as we look out at the face of crowds with masks on. But we're really not, we're focusing on COVID, but it's really a pandemic of chronic diseases that we really should be focusing on. Non-communicable diseases account for 75% of the deaths globally, And cardiovascular disease, predominantly, as you'll see here, through dietary risk, is a major contributor to those non-commutable diseases that are affecting life and reducing health, and really is the main cause of disability-adjusted life years lost. What we know is that from the years of 1990 to 2013, there have been about 11 million deaths that may have been preventable due to cardiovascular disease associated with diet, 241 million disability-adjusted life years that were lost, that these dietary risk factors can account for up to 87% of all these disability-adjusted life years. And there's been an increase in time, not a decrease. We are actually getting worse over time in the impact of these risk factors on disease. You see here in different colors, just important to highlight that the bluish, light bluish color at the top of the screen represents cardiovascular disease. So you see the major impact through dietary risk that cardiovascular disease has on the global burden of disease. When you look at these deaths and disability-adjusted life years attributable to globally to dietary risks, a couple comments that I want to kind of set the stage for our discussion. One is that there is substantial heterogeneity across countries. So I didn't list the countries, it's in the multicolored panel, but you see these are just different regions of the world, and you can see very different risk associated across. And to put it in perspective, China has the highest rates of diet-related cardiovascular deaths, attributable deaths, 299 per 100,000 patients. And Japan has the lowest at 69. And there are substantial differences between the diets of those two countries. And again, it highlights the fact that this dietary risk that leads to cardiovascular morbidity and mortality may be very amenable to change. The other thing I want to highlight is the fact that there are these different dietary risks. Some of them which you are aware of, like high sodium intake and low grain intake, low fruit and vegetable intake. But in the middle, I kind of highlighted, before further discussion, the importance of the fatty acids that we are intaking in our diet, and the fact that low polyunsaturated fatty acid intake is considered a dietary risk factor based on the global burden of disease investigators. So let me turn now to just presenting and a little on the Mediterranean diet. The history of this is quite interesting. It really dates back hundreds of years. The concept of a diet such as the Mediterranean diet, with high rates of fruits and vegetables, but really was popularized, I would say, by the work of the 7-country study in the 50s, where Dr. Ansel Keys, in a very well-known public health study, highlighted the differing rates of cardiovascular disease among individuals who ate a certain diet along the Mediterranean basin. And that was really the rediscovery of this diet and the focus of a public health innovations. There were you've been shown the pyramid, which I'll describe again, of the types of nutrients that exist in a Mediterranean diet. And there were 2 very important studies that I'm going to review very quickly. The Lyon diet study, which looked at a secondary prevention population of patients who had already had a myocardial infarction, and then a primary prevention study, the Predimed study, which Dr. Estruch led here, which I'll review briefly. And then, and let's get into that. So here is this food pyramid you've seen that's become quite popularized. To just highlight the components, this is a traditional pattern among populations living in the Mediterranean basin in the 1950s. This does not represent necessarily the diet of this population today. But it really was broken down into about 50% carbohydrates, 15% protein, 35% fat. You can see it promoted fresh fruits, vegetables, and nuts. olive oil, red wine in moderation, and a choice of animal proteins that favored fish over red meat, and tried to limit red meat and saturated fats and sweets in the diet. So it is important, it was highlighted before, but it's a dietary pattern, not a focus on specific nutrients. So the totality of the diet with all these components was really what's been evaluated. The first study, just to highlight very briefly, was this secondary prevention study, the Lyon heart study, which looked at randomizing patients with a prior myocardial infarction to a Mediterranean diet versus a Western diet. The Mediterranean diet supplemented with margarines that were high in alpha-linoleic acid, and you see a very significant and I think important result that suggested a reduction in subsequent myocardial infarction and other events which favored this Mediterranean diet approach. But I think it really is the PREDIMED study that has really advanced the construct of the Mediterranean diet as a way forward for primary prevention of cardiovascular diseases. And just to highlight some key features, this was a randomized controlled trial of nearly 7,500 patients done here in Spain. Patients at high risk but without prior known cardiovascular disease who were randomized to teaching around the Mediterranean diet with supplementation of either extra virgin olive oil or nuts, and the intervention, was the provision of, I think, a liter a week to a family of extra virgin olive oil. I can be corrected here, or 30 grams a day of a mixture of walnuts, hazelnuts, and almonds, I believe. And you see a very substantial and early difference between the control diet and the Mediterranean diets that were supplemented. It's important to note that this study has nearly 5 years of follow-up. The patients were enrolled between 2003 and 2009, and the study was stopped at an interim analysis as planned because of the efficacy. While there was some need for sensitivity analyses that were added that led to this publication in 2018, I think it's critically important to recognize that there was also data that would support a dose effect of the actual intervention of the actual Mediterranean diet. So compliance, the amount of compliance with this diet, which was measured by questionnaires, among other ways, was considered I think shows a good effect that the more compliant and adherent you were with the Mediterranean diet, the better the impact. In these analyses, you can see that this per protocol adherence adjusted analysis really highlights that while there was a benefit of both arms, experimental arms, it really was in those patients who were really quite compliant. The effect was even quite profound, with a number needed to treat that was quite reasonable of 26 patients 26 patients who were prevented from diabetes, or 13 prevented from cardiovascular disease for every 1,000 patients treated. So what have we learned and how has this advanced? Right now, I think there is changes to the scoring system. I think people are refining how we evaluate the adherence to a Mediterranean diet. There has been several secondary analyses of the PREDIMED study that have suggested the importance of the plant-based pattern compared to high animal-based pattern. Really a focus on highlighting perhaps a negative effect of dairy that perhaps was not well recognized. And increasingly, particularly in the U.S., there has been some advances in comparing this diet with more plant-based diets or vegan diets. This data is quite limited. I just presented really what I'm aware of is the only randomized controlled trial controlling the Mediterranean diet versus the plant-based diet only in 62 patients. And really, there was similar effects on blood pressure in this very short trial, but seemed to be that the Mediterranean diet doesn't necessarily lead to weight loss per se individually, while vegan diets are more focused on weight loss. So let me turn now to the components of fatty acid intake and how it affects cardiovascular health. And so here is this important work, recent work, that has looked at in the population of over nearly 100,000 patients between the Nurses' Health Study and the Physicians' Health Study from Boston, and looked at the mortality associated with replacing saturated fatty acids with different types of unsaturated fatty acids. And you can see mono-unsaturated fatty acids that are plant-based, it's MUFA-P, which would refer to olive oils, for example. The impact of replacing saturated fatty acid intake with plant-based mono-unsaturated fatty acids is quite well described in this large population registry to reduce total mortality. And when you actually look at the use of both mono-unsaturated fatty acids for both plants and animals replacing saturated fatty acids, you can see an effect on cardiovascular mortality. So it really is taking us and is having an impact on directives around dietary habits to remove saturated fatty acids from normal dietary patterns in the US based on these kind of data. Looking at a slightly different population, this is the largest, to my knowledge, population, a prospective population of over 100,000 patients who were evaluated through the NIH as part of the Association of Retired Persons as well in the US. And these patients were enrolled in around 1995, 1996, and were aged 50 to 70 years old at the time. And there are tens of thousands of events and disability-adjusted life years. And they looked at a very sensitive questionnaire and then followed patients based on that questionnaire for outcomes. And you can see with the outcome being cardiovascular disease mortality, you can see that if you replace isocalorically saturated fatty acids with monounsaturated fatty acids, particularly plant-based, you can have a major impact of 15% relative risk reduction on cardiovascular disease mortality in this primary prevention registry. So I think very important. Also, when you now look more specifically on olive oil, we have found through recent analyses of a similar cohort of the Nurses' Health Study and the Physicians' Study that higher olive oil intake versus individuals who don't consume olive oil, there is a 14% lower cardiovascular disease risk and an 18% lower coronary heart disease risk. And really, but there's no effect on stroke. So that's just a slight, I think, a finding that's been pretty consistent. The effects are on ischemic heart disease, these are not necessarily on stroke. Also important to highlight maybe the mechanisms of effect, that there is a reduction with the use of olive oils on pro-atherosclerotic inflammatory biomarkers, suggesting that that may be one of the mechanisms by which olive oils may lead to better outcomes. This is just to highlight that there are a multitude of mechanistic effects of polyphenols through olive oil as well as red wine that have been associated mechanistically with better outcomes. But these are all small or animal-based studies and really require further evaluation in human studies and more study. Just wanted to highlight one thing, which I think was very interesting, was this concept of the polyphenol content of the olive oil. And here in this secondary analysis of an ancillary study of the Praticò program, you can see 1,000+ subjects with 1 year intervention measuring this excretion of urinary polyphenols, that there was a difference between the Mediterranean diets and the controlled diets, with a reduction, with increasing excretion being associated with better outcomes, dose-dependent anti-inflammatory effects in biomarkers, as well as reduced blood pressure. So this is my second to last slide. I think there's a lot of work that's been done, but I think there's much, much more work that needs to be done. This is a preprint of our American Heart Association dietary guidance. It's not yet published. And as you can see, in this entire document, which spans nearly 100 pages, the word olive oil, is not found once. So I think it highlights the importance of that we need more work in this field, more information to actually have an impact on implementing changes in guidelines. The focus really is on liquid plant oils, but more Mediterranean-style diets in reducing cardiovascular health. But the particular role of olive oil still is felt to need further evaluation. So I hope in this short talk and time, I've convinced you that cardiovascular disease morbidity and mortality remains quite high. It's the largest contributor to the global burden of diseases. It represents the largest bank of preventable deaths, amenable to short-term population impact. The evolving evidence supports the role of these dietary patterns, particularly the Mediterranean diet, in the higher use of monounsaturated fats versus saturated fats in improving cardiovascular health. There have been randomized clinical trials to date, but increasingly we need to do more of that work in populations that are perhaps not part of the Mediterranean basis to see if the components such as olive oil and the dietary pattern that was shown to work so well in the Praticò study can be generalizable to other populations at risk. Thanks very much for your attention. I hope this was helpful.
Well, thank you very much for these magnificent lectures. We have time for 2 questions, one for each speaker. Okay, all is clear. Oh, sorry.
First question is regarding the dementia and Alzheimer's disease. In all these factors you have, most of them essentially were diabetes. However, there was no mention about environmental factors. We know that environmental pollutants are rising up, especially PFAS. So I see the community of the cognitive disease has not encountered yet the risk of all these pollutants. Can you elaborate on that?
Yes, absolutely. It's a very important question you ask. It's very actual. It's very little known. There's some research already done, at least in the preclinical model, that clearly shows that environmental factors such as pollution has an influence. But people didn't really look a lot on the dementia part. People looked more at like lung effect, peripheral effect. But we start to see something. But I think it's an area under investigated. I think there is a lot of things that we need to understand better. And I'm positive that there is an effect. But there is not a lot of data. It's not very known but it's an excellent topic that we need to know much more about it.
And I have one for Eric also.
Yeah, there is no mention of olive oil. If you search that entire document, olive oil is not mentioned once.
I guess that would be an excellent point, that once this comes to print, to be public, maybe we should write a commentary to circulation about that.
Yeah, I would like to add something, Eric, if you don't mind. I'm not shocked there is no olive oil there, because there is an industry behind. There is a lot of commercial interest there. I didn't present to you today data on another oil, canola oil, okay? We compare actually extra virgin olive oil with canola oil because they're both vegetable oil. So one of the questions we ask is, are all the vegetable oil in terms of cognition effect the same? Vegetable by definition is good. There's not a bad vegetable. I never heard of a bad vegetable. Well, guess what? Canola oil for cognition is bad. And I was personally attacked by the canola industry about my research. They wrote letter to the journal where the paper was published. They wrote threatening me and things like that. So I'm not completely shocked that the American Heart Association gets money from a lot of lobby company doesn't want to say olive oil versus other. Just says I'm very generic. That's my comment.
I would say, I haven't had your experience, but I think that is it's certainly possible and true. I guess I would say there's 3 new studies that I highlighted in my talk that come from 3 extremely large US-based registries. The Nurses' Health Study, the Physicians' Health Study, and the NIH AARP study of over 100,000 patients. Those 3 studies have all come out in the last year and a half. I suspect in response to the discussion promoting this guideline, because they've been very focused on evaluating for the first time in US-based populations the role of plant monounsaturated fatty acids and olive oil itself, because the questionnaires that underlie those registries were only updated in 1990 to even gather information on olive oil. It's almost been, at least in the US-based registries, until the 1990s, the information wasn't even collected in the 144 questions of the dietary habits of Americans. So I'm not surprised, because I think that it is part of the importance of implementing change in understanding. I have to say that really is kind of, I think, going to be accelerated by the results of Predimed.
Yeah, but I'm really surprised that I see plant oils and there are everything else but olive oil. And the thing is, we're trying to increase the consumption of olive oil in the United States. And as we know the lobbies are lobbies, and they're going for it. However, I definitely think we need to address that on a commentary once the publication is out.
Sorry, we have to cut. We have a lot of work to do in favor of olive oil. Thank you very much for the speaker and for the audience. Thank you.